Alrighty, welcome. This is Dr. Hether with the Hether macro for Chirotouch, showing you another example of how quick and easy it is to do an exam on a new patient. So when we open up our chart notes, we have our chart notes there. The first thing we look underneath the main menu button is examination and subjective findings. If I hit that button there, I can tell myself what type of exam, and the first two on the right are default as initial exams with chief complaints. So I can hit one of those two buttons and it takes me to today's date, which is the 23rd. And let's say I have two complaints. So I hit the complaint button, and from now on, I can go to the far right. And typically on the Hether macro, the next thing you're going to do is in red on the far right. So I hit the far right button for complaints and stiffness, and this opens up various types of complaints and stiffness. Under the main menu button, I can do many details: complaint, pain, stiffness, days per week, frequency, and adjectives. If I don't want to be that detailed, the one below that is just pains, complaints, stiffness, and days per week. And below that is just pain and stiffness. So typically on an examination, I'll do the second one down that says complaints, pains, and stiffness in days per week. So with this, I have 5 ways of saying the person's name, either their full name, their complaint, he said, she said, also has the person's first name. So it's not like every single complaint has the same rope statement. So let me go ahead and click that. I'll do my first name. Let's say I have neck pain, and today's neck pain is like a 1 or 2, and I'm having this stiffness in this area also, and I have this 2 days per week. With that, I can go on the third row, first one down, and says denies any radiating into the upper extremities. So I get that out of the way. And then I'll go over the patient stated TPS that they have upper back pain. Then we'll give that about a 0. And we're going to say that they have no stiffness with headaches, upper back pain. And let's say this happens 1 day per week. Now, with that said, their pain is 0, but they do have this 1 day per week. So if I go to the end of that sentence where I am now, I can do the far right where it says last felt or more pain on. I can go over there and I can put down that the patient last felt this pain yesterday, and they would have rated this at about a 4. So even though their pain in the upper back is non-existent today, they do have it once per week, and the last time they experienced it was yesterday, and it was a 4. Let's go ahead and go back to complaints and stiffness on the far right. And again, days per week, we'll hit that button. And let's go ahead and give her one last complaint of headaches. So if I say we have headaches, we can say headaches, and we have this about a 3, and we have this headache every day. So we're having headaches every day, upper back pain once per week, and we're having 2 days per week. We're having neck pain, which does not radiate into the upper extremities. From there on the far right, we go to etiology. We don't really know when this began, so it began about a week ago, so we can hit less detailed. From there, for these pains, they began about a week ago, and we can say that the condition is unknown and that this date is an estimate. Beautiful. So moving on, we can go right under, is there any other factors that may have affected this etiology? And if I put down unknown, I could bullet the patient denies having any recent falls, trips, slips, accidents, long travel rides, or any motor vehicle accidents. So that gets out of the way. So the next thing to do for our examination is our aggravating factors. What makes it worse? We can say that the person does not have any aggravating problems with standing. We can say that they do have aggravating problems with their neck pain when they walk, and we can say this noted after about 10 minutes. We deny any pain with sitting, and again, bending over doesn't bother it. We could then add any other descriptive factors using the microphone feature on the iPad. We don't have to type with that. Palliative is on the top. From there, what makes them feel better? Oh, they've tried Advil, they've done some heat, and they've taken a hot bath. Okay, beautiful. From there, we can either add another descriptive quality if they wanted to, or just skip right to their past medical history. Again, if there's an updated exam on a patient that was already existing, we won't have to do this. But we can just basically say this person denies having had any broken bones, any surgeries, and we can go down to this right here under other traumas. The way, And again, this person's not a female, so they didn't have any children. And I do a lot of elderly patients, so I always ask them if they've had any pacemakers or defibrillators. Sometimes they forget to put that on their intake. This person's young, so we're going to skip that. So let's go to their general health. Basically, the person has a little bit of, let's say they have high blood pressure. So we have hypertension, and again, sometimes get migraines with the headaches. Again, not female, so we don't have to mark down pregnancy. And if they were pregnant, we would just put down their due date right there. From there, we go into our review of systems. We can ask the person, do you wear glasses? And they can say, I have prescriptive glasses, yes. They denied any problem with hearing or smells. They have a little bit of food sensitivity, and on occasion, they have some diarrhea. But beyond that, they've had no hernias, no breathing issues, no chest pains, heart palpitations, diabetes or thyroid issues are negative, no skin irritations, no anxiety or depression or PTSD or numbness or sleeping issues, not a female for mammogram, and let's say that they have had a recent PSA and the blood test was normal going forward. And again, as I'm asking the patients these questions, I'm literally answering the iPad as fast as I'm doing right now. For the family history, they've already filled that in. They said they have a family history of heart disease. And from there, for alcohol, we can say that the patient does not drink any alcohol, they don't smoke any cigarettes, but has had a history of cigarettes. I will leave that one blank. And caffeine, they drink 1 cup of coffee a day. From there, we can go under employment. The patient is employed as, go back to that one. And then from there, we can say that who their primary medical doctor is. I like to ask the primary here because I give the primaries a copy of their evaluation. Dr. Smith, let's say. So when the patient's done leaving, I ask them, would you like me to send a copy of this evaluation to your primary? And then they say yes. Boom. We are done with the subjective findings. So we go into our vitals. We can ask them their height, their weight. If you have a scale, you can say that. 5'7", 180 pounds. We can say their blood pressure was 120/80. By the time I'm taking their blood pressure, I've done their temperature, pulse 64, respiratory 16, and 98.5. Let's go from there to visual range of motion. Again, on the far right, I like to look at their neck and their upper back. So we introduce the visual range of motion field. We go under cervical range of motion and ask the patient, please tuck your chin to your chest. They had no restriction with that. Mild restriction with extension, no problems with lateral flexion right or left, and mild restriction with rotational right and left. And the patient denied any pains with these ranges of motion. If they had pain, we would put it down there. We'll do that with the thoracic, saying that the person with the thoracics has, mild restriction going forward, mild going right and left, and they do have pain with flexion. From there, I'm going to add a period. Boom, and it takes us to our reflexes. Again, we did upper extremities, and they were all 2 by 2, so we'll say that those were all normal. We bulleted on the far right is 2s, on the far left are 1s. We have upper extremities, lower extremities, and then all extremities. From there, we go into the orthopedics, where we could introduce the heading of orthopedics for these complaints. Cervical had negative foramen compression. Lifting up on the head caused a decrease in neck pain. And when we did shoulder depressor, it was positive on the left, and this pain was mild. From there, we can say it was on the right side of the neck. And moving forward, we can go over to visual range of motion if we're looking at the patient's back or lumbar complaints or other cervical orthopedics. But from now on, being that's just cervical, I'm going to go right into that the patient has a positive cervical syndrome on the left. Regarding palpation findings, they were tender at C2 on the right and T2 and T3 in the middle. And from there, we can note muscle spasms noted in the cervical spine and also in the trapezius on the right and left. From there, we can ask the patient, have you had any recent x-rays? The patient denies having had any recent x-rays, so I'm going to send them out or take x-rays on my own. Why? Well, they have a history of past trauma. I want to see the areas that we're looking at, and they have limited range of motion, even though they did not have any neurological deficits or motor deficits or anything else that would warrant a need for x-ray. We're going to send them out for cervical and thoracic x-rays. Bam. We are done with our orthopedics. So while the person's getting set up on therapy, whether it's muscle stim heat or having someone help me with the ultrasound, by this time I just go into the next room and I work on my subluxation levels. Headaches in C1 and C2. I'm working with some lower dorsals, lower cervicals and upper dorsals. From there, I'm going to say that the person has cervicalgia without radiation, with upper cervical involvement that is associated with headaches, and that they also have thoracic segmental dysfunction along with thoracic spine pain. Their status is acute, and this is the first time that I'm seeing them, so they're under initial care. Their prognosis looks good. I don't expect them to have any ill will. If they had anything that would interfere, like history of past surgeries or any major arthritis, I can mark that down as a factor. But from there, while the person's on therapy, I ask them to fill out what's called a functional outcome assessment. You can use whatever test you use. I like the AMA's pain index because it gives me a wider range of questions, such as, does your pain interfere with your work inside or outside the home? 0 means they work normally, 10 means they can't work at all. And after the patient answered these 15 questions on a scale of 0 to 10, I can put down that their score was 25 for the neck, the thoracic was 26 for the thoracic spine, and my interpretation of this functional outcome assessment told me that these tell me that the patient has multiple regional functional deficits. So that also means the need for care. From there, we can go under other functional tests or any contraindicating factors, but we're done with our assessment. So to see this person, let's recommend a treatment plan of adjustments and therapy. We're going to recommend 2 times a week for about 4 weeks with 1 to 2 units of therapy. We're going to re-examine the person in about 4 weeks. And why are we doing the therapy? We want to do muscle stim and heat. And again, there's our rationale to promote healing for that. From there, what did we summarize our total visit encounter with the patient today? Under daily notes, we could say that today the person had an examination, an adjustment to 1 to 2 regions. They had muscle stim and heat. We are going to give them a copy of this evaluation report, and we're going to do an X-ray referral. And today we're going to give the patient some exercises as well as they completed some functional outcome assessments for me. And with that said, we go right into our physical therapy. We did muscle stim and heat on this individual for 15 minutes with the therapy lateral to T3, and we did it over the heat over the cervical and upper dorsals. We did this seated while the patient was sitting up, and today we moved into manipulations. What did we do for the adjustments? Well, I adjusted in a supine gonstead position, C1 and 2 on the left. I did C5 on the, 1 and 2 on the right, C5 on the left. And I also did another manipulation in a prone position of T2 and T3. How did the patient tolerate treatment? Man, they did really good. So I said they're going to do great. And for here, I put a dash. And the question is, well, why do I add a dash at the end of that? Because let's say the patient on a subsequent visit wanted to say, Doc, my headache went away right away. I can go to here, hit that little dash, and put down comment to their toleration of the treatment just at that point. I want the person to come back once more this week. And our goals are to decrease pain, increase range of motion. We didn't have any functional, we want to reduce their functional deficits, or even in this case, let's say we want to eliminate the functional deficits. We want to ask them their activities of daily living. I always do that on the next visit because I try to get the exam done and get a little bit of information so that on our second visit, we can ask them more detailed information that makes their case unique. I'll go over ADLs in a second. From there, they're not missing any work. And our goals, again, for the cervical, they scored 25. We want to see at least a 25% reduction within the time frame of that. We can change that 25 if you wanted to for 50. I just have 25 down as my default goal. From there, under home exercises, we want to introduce home exercises that we want to give them some cervical exercises for muscle spasms. And also for the thoracic, we'll give them some upper dorsal exercises. From there, we can do some patient education, how to avoid back pain, arthritis, or we can go under details regarding, I don't know, risk of caffeine, carpal tunnel, whatever other educational stuff we want to mention for the patient, we can add that at that time. So at this point, I flag it as yellow. Yellow is initial exam. Updates are darker yellow. Final exams are the darkest yellow. But in this case, when I add exercises, I get blue, but yellow and blue is green. So I'm going to flag this as a green, meaning I gave exercises as well as an examination so that I have this down. I mentioned the ADLs. On subsequent visits, when I do an ADL, I go under functional limits and improvements with care. And from here, we can just simply ask the person, what does your pain interfere with specifically? And we can go over that they have a problem with cooking, driving for 15 minutes, and laying down for an hour. They have problems with recreational activities and sports, and they have difficulty sitting actually, let's say they have difficulty in falling asleep for 2 hours. And again, this is kind of important for this patient. So what I'm going to do is I'm going to, on their second visit, highlight these, copy this, and under my plan, I'm going to update my plan as far as my goals for this individual, that we are going to add specific goals for this condition. We're going to ask the person today's date. We're going to say, based on their functional outcome assessments and their activities of daily living, based on chiropractic care, physical therapy, and home exercises, I expect to see an improvement within the following activities, and I'm going to ask the person to fill these same questions out in 2 weeks. And then 2 weeks from today would be, let's say, February the 6th. And I'm going to leave this on so that when I see the patient, I'm going to ask them, once they get past the 6th, let's go over those same goals and see what's improved and what isn't improved. And at that time, I can update their exercises, or their treatment, or their physical therapy is needed. So if we just look at the examination right here, it's pretty thorough. It says what type of exam it is. It tells me the complaints that they have, how many days per week, when it began, what makes it worse and better, their past history, their general health, review of systems, family history, personal and social, employment, and medical doctor. When we look over the examination, we have all of our vitals, our range of motion for cervical and thoracic, upper extremity reflexes, some orthopedics with positive findings, palpation, and with the rationale for ordering x-rays. We can see that their diagnosis has both subluxation and pain rating. They are under initial care. After a couple visits, I'll take away the initial. Their prognosis is good. Their ADL scores were scored. We have functional outcome assessments down there too. And again, here is my examination. Our plan was twice a week for about a month. Why I'm doing physical therapy, what did we do today, where was the therapy done, how was the adjustments done, how did the patient tolerate, return visits, goals, expectations, exercises for the patients for both the neck and the upper back, and specific goals with time frame. We're going to save this, and that's as quick as it takes to do an examination, and we are done. Thank you for watching. If you have any questions, please visit my website at hetherchiropracticclinic.com for more videos and information, and you're welcome to contact me regarding this macro set. Thank you very much.